All right, welcome back to Uncovering Bailey and Love. Make sure to scan that QR code you see on the album cover there to download the notes for this deep dive. And today we are going to be focusing in on the surgical anatomy of the breast. We'll really hit the high points that are relevant to all of our practices as surgeons.
Sounds good. So let's start by orienting ourselves with the general topography. Thinking about the adult female breast, the tissue extends vertically, I guess you could say, from about the second to the sixth rib. And then if you think about it more medially, it goes from the edge of the sternum all the way over to about the anterior axillary line, sometimes even the mid-axillary line. And of course, inferiorly, the inframammary crease is the landmark there.
And I think it's worth mentioning, of course, the male breast. It's not something we think about all that often, but it is important to keep in mind. It's essentially this little rudimentary disc of tissue, maybe a couple of centimeters across, that sits right underneath the areola. You don't want to get that confused with other things you might find there.
Right, totally. And speaking of things you don't want to get confused, we've got to talk about the axillary tail. So
Hmm.
that's that little finger of breast tissue that kind of reaches up towards the axilla. And and it's super clinically significant, right? I mean, you've really got to distinguish it from other stuff like, swollen lymph nodes or masses or even lipomas when you're examining a patient. And worth remembering that the prominence of that tail can actually change with hormonal fluctuations. So you're more likely to notice it, right before a period or during lactation.
Yeah, absolutely. All right, so let's dig into the parenchyma of the breast itself. So this is really where the action is, right? All the functional tissue, all the supporting tissue, all that good stuff. And I think it's fair to say the TDLU is kind of the star of the show when it comes to breast disease. What can you tell us about why this little unit is so important?
Oh man, the TDLU, the terminal ductal lobular unit.
Yeah.
Yeah, it's formed by basically you get your terminal ductal and then all those little lobules that cluster around it. And the TDLU, it's like super responsive to hormones, right?
Yep.
Estrogen, progesterone, prolactin, even growth hormone. And that's really important because it's that hormonal responsiveness that kind of makes it's like the main site where breast diseases start.
And of course, surgically, I mean, we're always thinking about the ductal system. We're talking what, like 5 to 9 major lactiferous ducts.
Yeah, somewhere in that range. Each of those ducts, they're responsible for draining, I don't know, maybe 10 to 100 lobules each. It's a lot.
Yeah.
And then the ducts themselves are lined by these myoepithelial cells, and they're kind of arranged in this spiral pattern. And that's what helps with milk ejection, right?
Yeah.
Because they can contract. And it's funny, you think about the TDLU and where they are in the breast, and it's not evenly spread out. I mean, about half of them are in the upper outer quadrant, and then maybe 20% are more centrally located.
Mm.
And that actually lines up pretty well with, where we tend to see pathology.
Makes sense. Focus your exam on those areas. And then what about the supportive tissue? Like what kind of scaffolding are we working with here surgically?
Well, you got to start with the fibrous tissue, right? And
Okay.
and the Cooper's ligaments are, I mean, they're super important. They've got these attachments that run superficially to the dermis and then more deeply to the pectoral fascia. And that's what really helps hold everything together.
And when those ligaments get disrupted, that's when you start to see those classic clinical signs, right?
Exactly. Yeah. And of course, there's more than just, fibrous tissue there. There's also the adipose tissue, which really contributes to the breast volume and shape. And then you can't forget the blood vessels and nerves and the lymphatics, which we'll definitely dive into more later.
For sure, for sure. All right, let's move down or out, or however you want to think about it, to the areola and nipple complex. I mean, there's a lot more going on there than just the surface anatomy.
Oh, absolutely. So you've got the involuntary muscles there.
Yeah.
You've got the Sappi's muscle, which is arranged concentrically, and that's what makes the nipple erect. And then there's the Meyerholz muscle, and those fibers are arranged more radially, and those are the ones that cause nipple retraction. And I mean, you can imagine how important both of those muscles are, not just for normal breast function, but also for like how we interpret clinical findings.
Mhm. Yeah, nipple retraction. That's always a big one for sure. And what about the areolar epithelium itself? Like, are there any special structures there that we need to be aware of?
Oh yeah, totally. So you have these sweat and sebaceous glands, and they're called Montgomery's tubercles. And what's really cool is they actually get bigger during pregnancy, and that helps to lubricate the nipple. And then the nipple skin itself is, it's pretty thick. It's kind of corrugated. And then if you look really closely, you'll see the openings of the lactiferous ducts kind of right near the tip of the nipple.
So many little details to think about, especially when you're, planning a surgery or thinking about potential complications. All right, let's move on to the lymphatics. I mean, this is a huge topic, especially for surgical oncology.
Could not agree more. The lymphatics are key. So
Yeah.
the main drainage pathways for the breast are the axillary lymph nodes and the internal mammary lymph nodes. And the axillary nodes, they're getting the bulk of the flow, probably about 85%.
And those axillary nodes, I mean, they're organized into these different groups that are really important for us to know, right? Surgically speaking, I mean.
Totally. So let's see, we've got the lateral nodes, then the anterior nodes, also called the pectoral nodes, and those are often the ones where we find the sentinel lymph node. And then you've got your posterior nodes, the subscapular nodes, and of course the central group. And then all the way up at the top at the axillary apex, you've got the apical nodes. And those apical nodes, they're draining upwards to the great veins or the thoracic duct or even the jugular trunk.
And of course, when it comes to surgical staging, we're thinking about those levels, right? Like, where are those nodes in relation to the pectoralis minor? That's crucial.
Absolutely. So level 1, those nodes are inferior and lateral to the lateral border of the pec minor. Level 2, those are the ones that are tucked underneath the pec minor, including those interpectoral nodes, the Rotter's nodes. And then level 3, those are superior and medial to the medial border. And that whole classification system, I mean, it directly impacts, how extensive our lymphadenectomy is going to be and what the prognosis is looking like.
Super, super important framework for any breast surgeon. And then what about the internal mammary nodes? I mean, we don't talk about them as much, but they're still important.
Oh, yeah, for sure. I mean, they might not get as much of the lymphatic flow, but they do drain that medial part of the breast, those medial quadrants. And they're kind of tucked away, running along those internal mammary vessels, deep to the costal cartilages, but superficial to the parietal pleura. And when those nodes are involved, it definitely changes things in terms of staging and treatment.
So the bottom line is, knowing the ins and outs of both the axillary and the internal mammary lymphatic drainage, that's fundamental to how we manage these cases surgically.
No doubt. It dictates our approach, how we do our sentinel node biopsies, how we do axillary dissections. It's all connected.
Well, I think this has been a really great, deep dive into the surgical anatomy of the breast. Really focused, really practical. I hope it's helpful for everyone out there.
Yeah, totally. We tried to keep it concise, hit all the key points. Hopefully it'll make a difference in your practice.
All right, thanks for listening to the show, everybody. We'll catch you on the next one.